not to put you on the spot or anything, but if you'll indulge me, can I ask you if you've received a vaccine?
I prefer not to respond to that question.
Okay, thank you very much. I'll just start by reading a quote from the Canadian Society for Immunology. We support unbiased, well-informed, and non-politicized scientific debate as vaccine rollouts occur with unprecedented speed. However, we strongly condemn concerted disinformation campaigns that misuse selected scientific data. These activities not only undermine the scientific process, but they also actively impair public health efforts and prolong the pandemic at great cost to us all. Based on the overwhelming evidence for vaccine safety and efficacy, we urge all Canadians to get fully vaccinated as soon as possible. Dr. Kalyan, do you disagree with that statement?
I certainly don't disagree with the feedback for having good, rigorous scientific discussion, and I think that has been lacking.
The question was pretty simple. Do you agree that Canadians should get fully vaccinated as soon as possible?
I believe it's the individual's decision. And I believe that education and understanding of the different types of vaccines and their efficacy and their safety, they should make that decision for themselves along with their doctors.
Thanks, Dr. Kalyan.
What we're watching is the Standing Committee on Health mandate debate. This video is a little long. Granted, everything in it is very important. Nobody is cut off. Questions and answers are in their entirety. Links are in the description below for the original live stream that was aired on Parallelview. We're going to start things off with Dr. Kalyan's credentials and preamble, then move on to questions and answers.
And so I thank everyone for the opportunity to speak today. The thoughts I'm presenting are my own as an immunologist and not necessarily those of my affiliated organizations. I'd submitted notes that contain further data and references for the issues I'll be addressing today, which involve Canada's vaccine mandates and the manner in which they have been implemented, which include the lack of recognition of infection-acquired immunity and the suboptimal data collection and availability required to evaluate the efficacy and consequences of the public health policies and mandates to guide evidence-based decision-making. So anytime a medical intervention is mandated, it needs to meet a fairly high bar for its justification. We should have a solid understanding of both the safety and efficacy of the intervention. Its purpose needs to be clearly stated, and we need to ensure that we have in place an ongoing surveillance to evaluate how well it is working to achieve its stated purpose. Now, with that base, a vaccine mandate may be justifiable if there was clear evidence that the vaccines we are using reliably prevent disease and its transmission. We have a clear grasp of their safety profile, which should be acceptable for prophylactic use for the disease in question. The mandate is not overly broad or unreasonable, and those subjected to the vaccine mandate can provide informed consent, which requires them understanding their own personal long and short-term potential risk from vaccination in view of their own personal risk of severe disease from infection. Now, it is clear, especially with Omicron, that the vaccines we have cannot really be relied upon to either prevent transmission or infection. An example, the first Omicron case in Israel came from a triple vaccinated doctor returning from a conference who passed it on to another triple vaccinated physician. The Omicron spread into many countries has been through fully vaccinated, often boosted individuals, and this really questions the validity of the current vaccine mandates for travel within and outside of Canada. Now, data from Ontario and other jurisdictions from around the world show vaccine efficacy drops below 0 after the end of the second month in those who are fully vaccinated, and boosters appear to show a similar rapid timeline for waning. So with this evidence, we should have moved quickly to lift heavy-handed measures and explain the evolving evidence. This is necessary for public trust. It is also good for public health to have a well-informed populace. Having a false sense of security has obvious negative consequences. So when it became evident during the Delta wave that the mRNA vaccines had poor durability in their ability to prevent infection and transmission, the messaging justifying mandates had shifted to the prevention of hospitalization and serious disease. And if that was the new purpose, then Canadians with infection-acquired immunity should have had their superior immune protection recognized from the onset. The data have been unequivocally clear that those who have had COVID-19 and recovered are better protected, as would be expected, from infection, serious disease, and death compared to those who are fully vaccinated. They would have also been less likely to transmit infection if they get reinfected, as their greater mucosal immunity limits viral replication better, unlike those who are fully vaccinated who experience a first breakthrough infection, who can have viral loads very similar to immune-naive individuals. Now, recent data from the US CDC confirms that vaccinating those who have infection-acquired immunity really provides them no real additional benefit. Thus, these already immune individuals are primarily being exposed to unnecessary risks, as rare as they may be, and they're also more likely to experience adverse effects following vaccination. So this lack of risk stratification for the blanket vaccine mandates has also been poorly considered for emerging vaccine-associated serious adverse effects. When the signal for vaccine-linked myocarditis appeared, it was repeatedly conveyed that the risk was far less than after COVID-19 infection. Now, data show that actually for males under 40, the risk of myocarditis is in fact greater after vaccination than following infection. The erroneous statements previously made in respect to this risk were never publicly corrected, which means that these individuals haven't been given the opportunity to provide proper informed consent. We're requiring those who are probably among the least likely to experience serious disease to be subjected to a medical intervention for which they bear the greatest potential risk of a non-trivial nature. As we move into the endemic phase of COVID-19 with Omicron, I hope we take the opportunity to investigate how we could improve our strategy, especially around blanket mandates for future pandemics, because they do have consequences. I'll just close now with the statements made recently by the head of vaccine strategy of the European Medicines Agency, the EMA, who had spoken directly to the lack of data and sustainability of continuing down the path of multiple boosters as a rational approach to the pandemic at this time. The EMA is aware that such an approach may actually do more immunological harm than good, and it is their position that further data is needed for the Omicron variant, particularly in respect to the utility of the current vaccines and whether different types of vaccines are needed now. Given the evidence and its lack, I feel this is the most reasonable and responsible approach. Thank you again for the opportunity to speak to these issues.
Thank you, Mr. Chair. And on behalf of this committee, I'd like to apologize to Dr. Kalyan for the intrusive nature of my colleagues' questioning with respect to asking you to provide individual health information. I apologize for that. Given that, Dr. Kalyan, maybe you could outline informed consent for this committee. I think that perhaps is germane. I know that you spoke a bit about it in your preamble, but maybe just the 3 or 4 points around informed consent, if you would, Doctor.
Yeah, it's the fundamental piece of any kind of medical intervention that a person understands their own personal risk from the intervention and their own personal risk from the disease in question. And so I'm not sure if everyone has been given, because it's an evolving science, especially around the new platforms, which are very promising, but we don't have very good longitudinal data. And so that's still coming in. And so to provide actual informed consent is challenging right now, because people's risks for both the disease is very disparate, as well as adverse effects. And we saw that, quickly. We moved quickly with the adenovirus vector vaccines when we saw that VITT, and especially in women, that it became less used in Canada. But we haven't really moved as quickly on the mRNA vaccines for young men, for example, and advising them appropriately.
Maybe Dr. Jacobs, just to start, because you've spoken to it a little bit, and it sounds like you're very adamant that it's important that people get vaccinated. What would be the most effective arguments to convince those that aren't?
Well, at this point, many of the people who are not vaccinated are in small groups, smaller communities. And I think if we're really going to get those people to get vaccinated, we have to reach out to them with very specific programs, whether it be a religious group, a cultural group, and you have to get in there and give them the information that they need to make an informed decision. So it's a ground game at this point. Earlier on, you know, we're always a little handicapped by patient privacy. If I could have shown people what I saw on imaging, if I could have talked to people directly about cases, I have no doubt in my mind that many people would have run out the next day and gotten vaccinated. I saw things that I had never seen in my career, and I've been doing this for a couple of decades now. I saw people on ventilators with torn lungs. That's not something that you see normally. So this has been an incredibly serious illness. But because of patient confidentiality, because of patient privacy, we're not able to speak freely about the impact on patients. I wonder if if we had had some way of getting around that, that we would have been able to better share the seriousness of the illness. But it's always a balance.
So fair to say that if Canadians better understood the health impact, they would make better decisions. Is there any evidence that anybody has that the argument that that most people who have chosen not to be vaccinated are misogynists or racist, that there's any evidence to point to the fact that Canadians who aren't vaccinated, many of them, to quote the Prime Minister, are misogynist and racist? Is there any evidence to point in that direction? And number two, the second part of that question would be, is there any evidence that making that argument convinces people to get vaccinated who haven't chosen to get vaccinated already?
It was a uniquely unhelpful thing that the Prime Minister did when he said that. It was politically driven. It did not help anyone in the healthcare industry. It did not convince anyone to change their mind. The people who remain unvaccinated right now are very much a mixed bag of people. Some of them are unvaccinated because they've looked at the research and they don't, and they disagree with the findings that the majority of healthcare workers and scientists have come to in terms of conclusions. And there are other people who are just simply afraid. There are other people who have been misinformed by social media. It's quite a wide array of people, and name calling is not helpful.
Thank you, Dr. Jacob. Thank you. Next, Dr. Pawlowski, please, for 6 minutes.
I wanted to question Dr. Kalyan, too. So I wasn't sure on your testimony where you seem to question the mandates, and admittedly, the vaccines aren't good at preventing spread of Omicron. But you yourself acknowledged that the reason for the mandates was kind of shifted to preventing hospitalization, ICU admission, and deaths. Do you not agree that that's a valid concern, and that the government ought to be taking actions in order to try to prevent hospitalization, ICU admissions, and death? And as Dr. Jacobs has told us, the fact that all of that also undermines the ability of the healthcare system to provide other health services. So am I wrong? But you're giving me the impression that you think that we shouldn't have any mandates at all, and you don't buy the fact that and there's tons of evidence about the vaccines, even with Omicron, decreasing hospitalization, ICU admissions. And I've got from Kaiser Permanente, they said 64 to 73% less likely people are less likely to be hospitalized if they've been vaccinated. South African study, 70% reduction in hospitalization for people who are fully vaccinated. This is Omicron. And also in Quebec, people who hadn't been vaccinated were 7 times more likely to be hospitalized, 14 times more likely to end up in ICU. This seems to me pretty good reason to be promoting vaccinations and social distancing if necessary, because those are pretty significant numbers. And even as of March 14th, there were 435 people in ICUs across Canada and 4,200 hospitalized COVID patients. So again, but maybe I'm misinterpreting you.
No, you're interpreting the data from randomized placebo-controlled trials. I'm not saying vaccines will not prevent hospitalizations, but I don't think coercion is the best way to get people to behave the way you want to. I think there are lots of health promoting activities. If you suggested people stop smoking, that people exercise, that they reduce their weight, there are many things that would reduce a hospital surge, but we never really did a more holistic approach to improving people's health, including mental health. And so I believe that if people are equipped with the information and understand their own risk profile, it is far more effective than putting blanket vaccine mandates, especially for people who already have immunity. And so that's really where I'm coming from. We need a better risk stratification, and Canada has never had a policy around which they would mandate vaccines. There are provincial legislations for certain childhood vaccines, but people have the opportunity to opt into that. So I really believe that informing people rather than forcing them to do something is always more effective for healthcare.
If I don't know, well, maybe I'll give the doctor from NACI, Dr. Warshawski, an opportunity perhaps to reply to Dr. Kalyan, or do you not want to enter into this debate?
Thank you, Mr. Chair. I can just provide some of the facts that NACI has been looking at with regard to vaccine effectiveness. So we do know that for 2 doses, the vaccine effectiveness against infection has decreases over time, and it can end up being quite low. But with 3 doses, we do see protection against infection of around 60%, and that does decrease as well over time. With severe disease, we see that vaccine effectiveness for 2 doses around 65 to 85%. And when we add that booster dose, we get protection against severe disease like hospitalization, which is in the high 90s. That may decrease over time. That's something that we're watching closely. Thank you.
Thanks for being here. Dr. Kalyan, you referred in your opening statement and remarks to infection-acquired immunity. How clear is the data regarding its strength and durability, and how does it compare to vaccine-acquired immunity?
So vaccines are trying to, it's actually the gold standard as far as when we recognize the immunity you get from infection, that's what vaccines are trying to mimic. And that's why our biggest successes around eradication have been from live attenuated vaccines, such as the smallpox vaccine, because they most closely mimic that infection. So we know that for COVID, it's been unequivocal that people who've had COVID and recovered are better protected from infection, obviously from serious disease and hospitalization, with the caveat that they survived the first infection. But given COVID is particularly, we know the risk factors associated with serious outcomes. There are a vast number of people who've already had COVID-19, and I think that with Omicron, we'll probably be in a better place as more people get that natural immunity.
Following you on social media, you're very pro-vaccine. Any thoughts on Dr. Kalyan's position as it relates to Omicron? It's a good opportunity to have a back and forth, and then if Dr. Kalyan wants to weigh in, glad to have her have the opportunity to too.
Well, I think Dr. Kalyan has made some very good points, and I think that we also have to look at that, but I have to also look at it from a pragmatic point of view in terms of what I see in the hospital. So to Dr. Kalyan's point, in terms of mandates, yes, Omicron was highly contagious, and no, the vaccine didn't do much in terms of preventing spread of COVID. If it did, it was minimal. So Omicron spread very rapidly. The previous Delta and other strains, there was a more robust prevention of transmission, but for Omicron it wasn't, and that takes away some of the need for a vaccine mandate, except, and this is a big exception, what we saw in the hospital were the patients who were immunosuppressed, elderly, so de facto immunosuppressed, and the patients who did not receive a full vaccine regimen they were the ones who were getting very severe COVID pneumonias. I saw a lot of people come in with COVID in the Omicron wave, but it was predominantly the ones who were unvaccinated, immunosuppressed, or frail elderly who were getting desperately ill from it. So from a larger population point of view, I can't make those arguments. That's more the world of NACI. But from an individual recommendation, those three groups, it would have been much better for them to have been vaccinated and boosted than not.
Dr. Kalyan, do you want to weigh in on this too?
Yes, thank you very much. So the trials around the clinical trials that were done never really assessed the ability of the vaccines to prevent transmission. And I haven't come across a component vaccine that is intramuscularly injected that is very effective in preventing transmission of respiratory viruses long term. So I think that understanding and having vaccine literacy is really helpful for the population. If we had an intranasal live attenuated vaccine, which would be a better type of vaccines for especially young healthy kids, for that more comprehensive trained innate immunity and launching an appropriate type of immune response to a certain type of bug would probably be a better approach to take. But we didn't understand, I think, when the mandates were put in, because we didn't have a lot of the vaccines we're using. Actually, we have very little clinical experience with. We have never used them outside of emergency use authorization. And so I think that was the surprise for me as an immunologist, that we started mandating the use of these vaccines without having, the clear data. And the companies themselves are just starting to release the the anonymized patient level data. It might take they wanted not to release that for the next 75 years, but we're starting to get some of that more clarity on the type of efficacy that really the vaccines have in a placebo-controlled trial. And so I would have, of course, want to look at the risk benefit, and that's where the risk stratification would have been really helpful to identify. We know, by May 2020, that 95% of the mortality COVID related when we didn't have vaccines were in those over 65 years of age. So I think if we had focused on, protecting the most vulnerable, would have gone farther than putting blanket mandates on everyone, because that has really, I think, that actually has the potential to increase vaccine hesitancy and trust in vaccines and the public health care system in general in terms of recommendations. And so I do believe that we should be focusing providing immune protection and being transparent and looking at the evidence when we have an immune escape variant like Omicron. How much data do we have that giving multiple boosters is going to be helpful or is good for people? So we really need to diversify. The first time I spoke to the committee members was back in June, and I'd really strongly suggested that we diversify the portfolio of the type of vaccines we have available to Canadians. And so we put all our eggs in one type of basket. And so we've seen we're still in a similar position, but with Omicron, it's a far less severe type of infection. So I understand that people who are frail and don't have good immunity, they require some type of
Thank you, Dr.
more
Kalyan.
protection. Yeah.
That's what a good conscientious debate is supposed to look like. Although it looks like the Liberals come in a little ill-prepared. I want to know what you think. Leave it in the comment section down below, and we'll see you in the next one. This guy